This conference will now be recorded.
Okay, I want to welcome everyone to the Tuesday, January 26th edition of the High Risk Recurrent Advanced Prostate Cancer Support Group. My name is Len Sierra, and I am a heroin addict. Oh, sorry, wrong group. Or attempted human death. All right, so we do have a new member tonight, Franklin Dunn. And
That's
Franklin,
right.
we have a format where I ask you questions and you give me answers, and then eventually we open it up to everybody. So, first of all, is it Franklin or Frank, or how do you prefer to be called?
It's Franklin. There were a number of people, one person named Frank, another person named Frankie. So I stuck with Franklin's to keep things simple.
Yeah, that helps. Thank you. So, Franklin, how old are you?
I will be 76 in April.
All right. And where do you live?
I live in Guadalajara, Mexico.
Well, how about that?
We got international callers tonight.
So let me just say, Franklin, that you're not the only gent on here from Mexico today. There is somebody else on here from Mexico, as you'll find out with time.
I was just going to say hi to Franklin. I live in San Carlos, Mexico, which is Guaymas, close to Guaymas in Sonora.
Nice to have a neighbor.
And you stay in a lovely city. We toured Guadalajara and down to Aguatique. It's a beautiful area.
Thank you.
Yeah, back in my day, I recall anyone who didn't get into a U.S. medical school would go down to Guadalajara. I'm sure that's changed now, but this is the way it was some 50 years ago. Anyway.
That hasn't changed, Len, at all.
Okay.
There are still a lot going down there, and they really do a good job. I think the problem with them is the ones that come back to the U.S. have to go through a test, and that's write prescriptions in the U.S. If they just stay in Mexico, they can't write scripts for the U.S.
Yeah, that's true for anyone coming from a foreign country, I believe. So, Franklin, getting back to you, how did you hear about AnCan?
Well, I'm a member of a couple of. I'm a member of Zero Prostate and Us Too, and I don't know. It was through one of those organizations, I believe.
Probably Us Too.
Okay.
All right. And what year were you first diagnosed?
I was diagnosed in October of 2017.
Okay. Do you remember your Gleason score and your PSA level at diagnosis?
The Gleason score was 9 something.
Okay.
And I know that it's divided between two different numbers, and
yes.
the one that you don't want to be the higher one was the higher one.
Okay, 5 plus 4.
That explains that. Yeah.
Okay.
And the PSA, which had always been traditionally low, I joined I guess you'd call it a clinical study some years ago, where they were trying to discover whether zinc, selenium, and gosh, I can't even remember what the other one was, vitamin D.
Vitamin D.
I'm sorry? Anyway, I was a member of that study for a number of years. And that always included a yearly physical exam. And my PSA had always been low, I mean, I remember it vaguely now because at the time it never worried me. It was always like 2 to 3 or 3, something in that range. Never what I considered high, and never anything to be worried about. And then they found out that there was some issue with that study. I can't recall which it was, whether it was the zinc or the selenium, excuse me. It was zinc and selenium and something else that, or maybe it was just a multivitamin. But anyway,
Yeah, it doesn't matter. What was your PSA when they diagnosed you?
oh, I'm sorry. Okay, my PSA when they diagnosed me was about 10 something.
10. Okay.
Hmm.
Thank you. And which doctor did you see and at which institution and where was the location?
Okay, I had what they call here a TERP, and they did a biopsy. The urologist did a biopsy, and that's when they discovered it. So it was not really a medical institution, it was urologist's office, and he immediately, then I immediately wanted a second opinion, and so I got in touch with Memorial Sloan Kettering in New York.
Okay. And who did you see there?
I saw Dr. Lewis Kampel,
How do you spell the last name?
Kampel.
Okay. And I presume that he's an oncologist and that he specializes in genitourinary oncology.
Urologist.
Right. I as soon as I got an appointment with him, I flew to New York, and he gave me the second opinion, which confirmed the diagnosis that I had gotten here.
Okay. And before you began any treatment, did they do any scans?
Yes, they did scans and blood work. Yes. Yeah. Hmm.
Okay. And what did the scans show?
Metastasis in, different areas of the body. There was also a spot on the liver.
Liver and several bone metastases?
Yes. Hmm.
Okay. All right. So what was your primary treatment? What was the first thing they treated you with?
Docetaxel, I think, was the first one.
Okay. And how did you respond to that?
Well, it worked for a while, and the PSA went down. I'm sorry?
Keep going.
Okay. But then it stopped working, I guess, and, they proceeded through a different
I'm getting feedback from the machine.
Jake, could you mute Russell?
I got him, guys.
Thanks.
Okay.
I was looking for him. I couldn't find him. Thank you, Bill. Yeah, and please, folks, if you're not going to be speaking, please mute your microphones until you're ready to speak. Thank you.
Thank you, Jake. Okay, Franklin, continue. So the docetaxel worked for how long? First of all, what did it drive your PSA down to, and in what time frame?
I'm sorry, I don't have the figures in front of me. I didn't realize that would be the direction. I need to get that information better in hand, but it was lower. It was about a 4, a 3.
Okay.
But then
And
it
when they
stopped.
decided it wasn't going any lower, what did they switch you to?
Well, I have this list here. I began a regime of chemo and hormone therapy, which included Lupron, docetaxel, cabazitaxel, and most recently, abiraterone.
Abiraterone, okay.
Abiraterone, thank you.
So that's quite a few drugs. Was that in which order did you take them in? You had the docetaxel first, then Lupron?
Yeah, no, I think the Lupron, I began, they did it simultaneously.
Right. Okay.
So I think the order was Lupron, docetaxel, cabazitaxel, and the one that you just mentioned, which I still don't know how to pronounce,
Okay.
which is what I'm still on right now.
Okay. And
Abby.
so you took the cabazitaxel along with the abiraterone. Let's just call it Abby.
No, I don't believe so. I think when I started taking the Abby, I discontinued the previous one.
Okay.
Right now, I'm only taking the Abby and the prednisone.
Right. So how did you do on the cabazitaxel?
How did I do on it?
Yeah, did it help?
Well, not enough for them to just keep me on it. That's why they moved on to the Abby.
But I mean, they gave you the full course of treatment with cabazitaxel, or
Yeah,
they stopped it early?
I'm sorry, I don't know the answer.
Okay, that's fine. And have you had any scans since your first scans when you were diagnosed?
Oh, I've had several, and most recently, the most recent set of scans that I had, it showed, well, according to my oncologist here, the cancer has progressed, the lesions, as what is what he said, have progressed by 44% since my initial diagnosis.
And do you know what type of scan that was?
It's the most,
PSMA PET scan?
I beg your pardon?
Does it sound something like PSMA PET?
Yes, yes, that's correct. Uh-huh.
Okay. And that was at MSK, Sloan Kettering?
Well, no, I had it done here, and then I sent the results to my doctor in New York.
Okay.
Len, I would doubt that was a PSMA. It was probably a PET.
Yeah, me too.
Why do you say that?
Well, it's only just approved in December in the US, so it's unlikely it was approved earlier in Mexico.
You could be right, but
Franklin, we haven't heard of any PSMA testing being done in Mexico at this point. We know it's being done in Canada, in the UK, in Australia, but it's not that widespread. So if it is, we'd be really interested because there are a lot of guys trying to get access, and Mexico could be an easy alternative. I'm sure somebody like Jerry Pelfrey would be very interested to hear if a PSMA scan is available in Mexico.
it says here PET/CT, and then there's a small number 18, and then it says PSMA.
Okay, well then that's really helpful information for all of us. Excellent. And where did you have that done?
Here in Guadalajara at a lab called CHOPO, CHOPO.
Okay. Jerry, you got that? Give me a thumbs up. Okay.
Look at that, you're helping us already, Franklin.
Well, I'm pleased, I'm happy.
Okay, so what is your current PSA?
Actually, I kind of like, to be honest, I sort of blocked out. It's now up to about 400.
Okay. We've had guys higher than that. All right. So did you ever have any genetic testing done?
I believe I did when I first went to Memorial Sloan Kettering, and again, it's vague, and I apologize. I think they told me that, you know, whatever that genetic testing might have helped me with, it didn't help. It wasn't useful in my
Right.
case.
I understand. Okay. So do you have any specific questions for us before I open it up to everybody?
Well, I just thought I'd let you know that I'm due to start on carboplatin on Thursday.
Okay.
Yeah. I've had a lot of, if you give me just 3 or 4 minutes, I'd just like to tell you where I am, okay?
Sure.
Psychologically and physically, etc.
Okay.
I got sober at the age of 28. I stopped drinking and smoking, and I really embraced a healthy lifestyle. I used to run every weekend on races and stuff like that until I decided it was better to swim. And then I became a master swimmer. I joined a master swim team, and I was always in a good age category, so I could always get a medal. But the point is that I lived this super healthy lifestyle for years, and so this was like like a shot in the dark for me when I got this diagnosis. Anyhow, my body, because of the chemo or the lack of exercise or everything, my body has really changed in the past 3 years. My whole physical being has changed in ways that it's still hard, very, very hard for me to accept. I guess, yeah, I mean, oh, I know. And then the last conversation I had with Dr. Kampel at Memorial Sloan Kettering, and my doctor here, who was a qualified oncologist, he's probably considered one of the best in Mexico. He has his own big clinic and everything. Always does what the doctor in New York says. He always follows to the letter the instructions that he gets from Dr. Campbell in New York. A doctor here by the name of Dr. Morgan. But in any case, so I've been following the New York protocol, if you will, ever since
Right.
it began.
So
I don't know. There was
so
another.
you're-
Yeah, I know. The last thing, just quickly, the last thing, Campbell told me that we're going to go on this new platinum, whatever it is, he said. And I asked him, I had read an article in the New York Times about some new protocols that are being developed at the University of California. Basically, they are not yet being treated, they're not yet being used to treat prostate cancer, but they're being used to locate cancer cells. And if you want, I'll share that article with you later on. I'm sure probably many of you have already seen it. But I discussed that with Dr. Morgan here, and he said, yeah, it'll probably be 10 years. And Campbell in New York more or less agreed with that. But then Campbell said that there is a clinical trial at Memorial Sloan Kettering, and I need to demonstrate my eligibility by giving them a history of everything that I have taken, my whole medical history since since I got my diagnosis in October of 2017.
Right. And so did you say this was a diagnostic or treatment?
The California treatment is at this point, a diagnostic treatment. The one in New York is a clinical trial relating to treatment, as far as I understand, from Dr. Kampel in New York.
Okay, but you're not sure what the treatment is.
Yeah.
No, I'm sorry, I don't have the
Okay,
information in front
that's
of me.
fine.
It
All right,
sounds
so
very
let
much.
me open up questioning here. And we do have at least one person I'm aware of who's done carboplatin, which is Peter Kafka. Would you like to say anything to Franklin, Peter? We can't hear you. You're muted.
Yeah, Franklin, I did my carboplatin last spring and spring to summer, but I did it in conjunction with docetaxel. I did the two of them together. I don't know anything about taking it by itself. I don't know what the protocol is.
There is another medication I'm supposed to be taking with it, and I don't know the name of it yet, but he said it was something to do with growth. So it might be, I don't think it's docetaxel, but it's something else.
So it sounds like you
Probably GCSF.
I have the appointment on Thursday, and that's when I'll learn what the accompanying medication is.
If it has to do with growth, it's probably GCSF, growth stimulating hormone, like Neulasta or Neulasta.
that's a good guess, Jake. Probably is.
I have a feeling, from having you mentioned that that's one I already have taken.
Right. Makes sense.
Would anyone else like to talk to Franklin or ask questions?
Yeah, hi, it's Larry Fish. Well, sorry to hear you're really a solid member of this group, Franklin. I see my oncologist at Memorial Sloan Memorial Sloan Cancer Center, MSKCC, and it's interesting that I spoke to her because she's the PI for the newer Sloan Kettering BITE trial, which is ongoing, and we discussed eligibility, and she said, well, you had to have failed on chemo and failed on second level androgens before you could be eligible. It wouldn't be yet eligible, but that she was doing that study. So it may be the Sloan BITE trial, which is kind of interesting and exciting if you have a chance.
I'm kind of not hearing everything you're saying. Who was the person that you spoke with at Sloan?
Well, my doctor at Sloan is Dr. Karen Audio.
I think she has a radio on in the background.
Really? Do I? Well, I have a TV in the other room. Can you hear that?
Oh, yes.
Yeah, we
Very
hear the TV in the background.
Wow. Oh, I'll shut it off in a second. I have to go in the other room. I'm surprised. Usually no one can hear. Hold on. I'll be right back. Let's go on. Keep going.
I'm sorry to bother you like that, but I can't hear what you're saying, and what you're saying is important to me.
Yeah, I had trouble hearing him as well.
I didn't get the name of the doctor he was talking about.
So let me repeat on Larry's behalf. Larry's doctor is Karen Audio. I think it's spelled AUTIO or AUDIO. She's researching an area that we talk about here quite frequently called BITE trials. That's a capital B, small I, capital T, capital E, which stands for bispecific T-cell engagers. And those are trials that seek out the prostate cancer cells specifically, as you were mentioning, and bring T-cells into those prostate cancer cells. Now, that there's also similar technology with PSMA, just like you had a scan, but instead of using the PSMA for scanning, you can use it to introduce a radionuclide. You can also use the PSMA in a BITE trial to introduce a T cell. These are all fairly new. I don't think they're 10 years away, personally, but that's just my opinion. There are other people on the call that might disagree. So you might want to talk to Dr. Kampel about BITE trials and also about radionuclide, RADIONUCLIDE, radionuclide PSMA trials. We're not talking about radium-223 Xofigo, which is approved. We're talking about much better and much more focused treatments than that. The one thing I would suggest you do right now, if it were me, this is what I would certainly be doing, is I would try and find a lesion, maybe in your liver, if it can be biopsied, otherwise give some blood and get genomically tested again, because the cancer changes over time. And if they first did your genomic analysis back in 2017, if you have had a whole bunch of treatments since then, which you have, 2 different types of chemotherapy, abiraterone, your disease could have changed. In fact, it probably has changed, which is the reason why they're putting you on carboplatin. And there may be a clue to a new treatment for you. So this can be as simple as a blood test today, done by somebody like Foundation Medicine. And you'll give blood and it will get sent off and it will be analyzed again. Now, I don't know how you handle your medical care. I do know that Foundation Medicine has got some very good programs for people that are in Canada. I've never asked about Mexico, but in the United States, this test is covered by Medicare. So if you got it done at MSKCC, it would be covered by Medicare.
Well, thank you very much. I have a quick technical question. This conference is being recorded, and the recording will be available after the conference?
Okay,
Yes.
so the answer is yes, and in order to access it, we suggest you go to our website. Have you been on our website?
I don't believe so.
Okay, so our website is ancan.org, Alpha, Nancy, Charlie, Alpha, Nancy, ancan.org. We're putting information for you also in the chat window. There's a little bubble in the top right of your screen. And if you click on that bubble, you will find things in there. You'll find links. Jake just put the link in. I'm going to put it in so that it can be active when you go there. And if you click on that, then you'll go directly to the website and to other things. Now, on the website, if you sign up for our blog, on the blog page, you will get automatic notification because we post it to our blog. You'll also find it on the website under recorded calls, I think it says, or recorded groups. It's under resources. It says recorded groups. You can find it there. So those are 2 ways. Those are probably the 2 easiest ways for you to find it.
Thank you.
All right, Franklin, I'm afraid we're going to have to move on. Come back next week if you have more questions. And as Rick suggested, go to our website and you'll see a lot of information there. But we have a number of other members that we need to get to. So thank you for joining us today. I hope you'll come back. Yes, John, we can't hear you, John A. Nope, can't hear you.
Select, you need to select that mic that you're holding.
Yeah. Anything there?
Yeah, there you go.
Okay, must have had the wrong mic selected. I wanted to say quickly, Franklin said that like very many of us on this meeting, that he in the past has been a fine athlete and that he and therefore probably was implying how much has been lost in the last few years since diagnosis. And I just wanted to tell you how many of us know exactly what you're talking about and continue to do our very best to stay active. When I'm out running, sometimes I can't help but think that in the past I ran this same thing at 3 times the speed or something like that. But I try to put that out of my mind because I'm not out there running to make myself feel bad, but to just do my best now. So just to make a little comment about the emotional side of things for us and for our new member.
Very kind of you.
Let
Thank
me just answer
I'm
one
looking for
one
my
sec.
support.
So I also echo what John said. I was a marathon runner and, you know, in great physical shape, and all of a sudden this hit me like a ball of wax, you know, just knocked me over. But the other thing is I think if you're physically active now, it will help. Are you still physically active, Franklin?
I'm about, no, I'm not. I actually, I was swimming up until I think, like maybe, I don't recall. And then everything was closed because of COVID. And then they reopened the pools and I was able to go back to swimming. Probably, in fact, in December, that's what one of the things that struck me is you know, I did my laps in the pool at the place that we went to for holiday. And I was exhausted after 3 days of doing that exercise. And I barely walk now. I walk with a cane now. Running is totally out of the question. I just don't have the physical strength or the stamina to do what, you know, it's almost only sometimes to do the daily things like take care of myself, like take a shower and shit like that.
Franklin, let me interrupt because, as I said, we really need to move on. We do have another group called Speaking Freely, where they talk about things that are not treatment related, but more emotional or psychological effects of prostate cancer or other cancers. You'll find that on our website also. And I'm afraid I really need to move on.
Speaking Freely, thank you.
Yes, thank you. All right, I want to go to Carl. I see you're here, and I know that you'll want to talk to us, and we'll be interested in hearing what you have to say. But also, I want to go to Jake Hannum first. He has some updates for us.
And Len Nazir also joined.
Yes, Nazir too. Sorry. Go ahead, Jake.
Okay, I've been on docetaxel for 210 days. After 204 days, my PSA doubled from 84.8 to 169. I'm having another blood test tomorrow that chances are I'll be doing something else in the near future. And I'm out of breath, sorry.
That's okay. And so I think from prior conversations, you said you were thinking of doing cabazitaxel next.
Well, I'm assuming that's her going to be the next, her next choice. I don't know that. I haven't talked to her yet. I'll see her tomorrow.
Oh, okay. All right.
Jake, are you still on Lupron?
Yes.
So Jake, is there any chance you can just do one of these Foundation Medicine blood tests soon to see if things changed?
I asked my doctor, yes. I sent her an email asking her to put me in for it. So hopefully within the next week or so, they'll get the kit.
I mean, that could provide useful information.
Yeah. Yeah, Rick recommended that to me the other day. So.
Yeah, and Jake and I spoke last night, and I mentioned to him that sometimes after docetaxel, he was on enzalutamide previously, and sometimes after a round of docetaxel, you become resensitized to enzalutamide, so he may consider that also, in addition to the cabazitaxel.
Right.
Anyone else like?
That. I would prefer that to cabazitaxel for sure.
Yeah, I'm sure. And I think you mentioned Ken Anderson. Do you know what the washout period is between rounds of chemo?
You know, I only know that part that relates to being eligible to a clinical trial. It may not be the same. You know, it's 28 days after chemo, your last round of chemo before you're eligible in most of the trials. But honestly, Paul, I think in Paul's comment, he was referring to like 3 months. Because it's pretty harsh going from one taxane-based drug to another one. So I don't know.
Yeah.
Well, if it's any consolation, Jake, as I think you know already, when they had a patient preference crossover trial, cabazitaxel versus docetaxel, something like 70% of the patients preferred cabazitaxel. It's not quite as harsh as docetaxel.
Yeah, I've heard that too. I'm not so sure. So what I've read about it is got a lot of side effects too, but we'll see.
Yeah.
Just also, Ken mentioned alkaline phosphatase. My alk phos went down to 61 from 70. So you would think with the doubling of PSA that the considering that most of my mets are in my bones that we know of, the alk phos is staying pretty low.
Jake, remember we talked about your prostate ablation years ago. You only had a quarter of it frozen, you said?
Half of it, yeah.
Half of it?
Yeah.
I mean, some of your PSA, I don't know about, alk phos usually comes from bones. So with that being low, it's coming from something else. And it could be coming from your prostate. You know, that's just my thought.
It's a good thought, and you're probably right, Ken.
Jake, I want to say one other thing to you too, which is that just be really careful of Dr. Google. If you read the side effects from Xtandi, you wouldn't want to take that either. So yes, you can read about these side effects, but they put in everything under the sun. And I think it's a lot more reliable when patients who have taken second-line anti-androgens versus cabazitaxel report that they like the chemo better. We've had guys on cabazitaxel who have barely noticed it. They've done really well. I think the big issue for you is, yes, it is a follow-up to docetaxel, but I've never seen it used immediately. Docetaxel fails. I don't know whether it is used like that. Herb, it looks like.
Well, theoretically, it would be surprising if it worked well, just because it's the same mechanism of action. It's a Taxol-based drug, the same mechanism. And if your current stuff is kind of escaping Taxol, I might think of some other approach.
For example,
I mean, you could try it for a short period of time, and you'll see very quickly whether it turns around the PSA. But I think if we could think of some other approaches that you'd like, that could help you, I think that would be another way to go.
Franklin was just talking about using that approach. He used docetaxel first, then when that failed, he went to cabazitaxel.
But was it right after, or was there something in the middle?
Franklin, was there, Herb, go ahead, ask the question to Franklin, please.
Franklin, when you were gone from docetaxel to cabazitaxel, was it straight away, or was there something in the middle?
I think there was something in the middle, and I'm trying to look and see what it was.
Right.
I'm sorry. I don't
I mean,
have
so
on front of me.
Peter, what would you think about cisplatin?
Are you asking me that, Herb?
Well, either Ken or Peter or somebody who knows more about it than I do.
I haven't even looked at that one.
I would get the I would get the genome test first and see if see if it can help target something. I know Jake already has a genetic mutation that has not shown to be, treatable by carboplatin or anything else, but maybe things have changed.
Well, it's not been shown, it wasn't shown to be treatable with a PARP, Peter, but I don't know about a platinum-based drug. And Herb, usually if it's a platinum-based drug, the first one of choice is carboplatin. I mean, I think I've seen cisplatin used a couple of times, but not very often. And anybody ever heard of somebody getting cisplatin?
Well, I'm not. I was talking generically about platinum. I wasn't meaning particularly. I think going to a different mechanism of action to me makes a little more sense here.
Right. So yeah, platinum drugs are used as you hear with Franklin and Peter, because he had the peritoneal mass, and usually they'll do that if they think the cancer has morphed, has changed its form. And as it changes and becomes more like and looks more like neuroendocrine small cell disease, there's a likelihood that they will prescribe a platinum-based drug, sometimes along with sometimes along with taxane, and I guess sometimes on its own. Although again, I'm not sure I've heard of it solely on its own. But yes, it could be an option.
I think that's what Franklin said. He's going to be starting on Thursday. He's going to start carboplatin.
Yes.
So.
Yep. Because Franklin, even without seeing a new genomic analysis, and the way that Franklin's disease has gone, and the fact that it's now evident in the liver, makes him a good candidate for a platinum-based drug.
I should add quickly, if I can, that the original diagnosis included a spot on my liver, and in order to verify that it was indeed prostate cancer, I had to have a biopsy on that spot. And anyway, it was proved that I had the spot, but after the first treatment with the docetaxel or whatever, the spot disappeared. So it looked as if something had happened, and now apparently a spot has come back on the liver.
Okay. Well, the good thing about a spot on the liver is that it is biopsyable, and the best thing to biopsy is a soft tissue sample. So that soft tissue sample may be very helpful to do another genomic analysis.
Well, as I said, I did request I asked her to submit a request to FMI for me. So my data, I only sent it to her over the weekend, so she probably won't get it, the kit yet, but hopefully by next week she'll get it.
Okay.
All right, Jake. Well,
Thank you,
of course,
gentlemen.
we certainly hope that it was a lab error, but you'll let us know.
Now we're all thinking about you.
I appreciate that. Thank you, Peter.
Yes.
For sure, Jake.
Thank you, everyone.
All right. Herb, you probably have just a quick update for us about
No,
your radiation.
Nazar is here. I thought we'd go to Nazar or.
Well,
No.
I'm the leader here, and you will obey me.
Okay, my quick update. I finished 5 rounds of SBRT last Friday. I have absolutely no side effects. I wouldn't have known that I had the radiation. I just came home every day and acted normally, did my exercise. So that's great. Now I'm getting back to my regular diet because the diet for SBRT is terrible. And then I had a COVID shot yesterday. So that's the update.
All good news. Wonderful. And when will they check your PSA? How far after your radiation?
I mean, my next PSA check is probably 2 months, but according to what I am told and read about, it's given that I'm on Abby, the PSA decline could be very slow, and it could even go up.
Yeah.
So
Okay.
I'm not that eager to get it so soon.
Okay.
Could you
So,
explain that a bit, Herb?
Who?
It's John. I was wondering if you could explain that, given that you're on abiraterone, how to interpret those PSAs.
Well, I mean, already abiraterone is really keeping the PSA pretty low. I mean, my last measurement was 1.7. And so, and then according to the radiation oncologist, he thought it would take a year before we reach a nadir. So I don't expect it, but you could get a big burst of PSA from killing a bunch of cells. So it's really not easy to predict. And I guess I just decided to be cool for a while and just hopefully it'll go in the right direction.
So Herb, was the wife disappointed that you were completely normal after the SBRT?
She was thinking she'd have to carry me home.
Oh, I thought
But,
you were thinking maybe the SBRT would finally turn you into a big mensch,
That's a hard one. That's a hard
I'm sorry, what is SBRT?
You don't have far to go, Herb.
SBRT, it's stereotaxically radiation therapy. So it's very much guided radiation. In contrast, and it's 5 sessions called hyperfractionated doses. So you get 5 sessions of very high radiation in contrast to what used to be 49 sessions of low dose, which was IMRT.
Similar to CyberKnife.
It was the CyberKnife machine, but as we heard from others, there are other machines like the ViewRay machine which do the similar things.
Herb, when I had my SBRT last February, on the day of the first SBRT treatment, I had 3 of them. My PSA was 1.26. A month later, it was 1.76. So there is a flare, a normal flare after SBRT. Then it's started going down after that, the months after that, and now it's further down. But yes, there is a flare normally after SBRT.
So we'll just have to see. Okay, thanks,
All right.
Lynn.
Okay, if we move on.
Yep.
So let's go to Nazir. Nazir?
Yes, sir. Thank you. I'm here.
Okay.
Okay. I am on a trial, which is 3475921. It's a double-blind trial, and I do have a little bit of difficulty understanding whether I'm getting the Keytruda as well as the docetaxel. But I don't know. I like to find out. But I do have problems. My legs are hurting badly, and I do take some Tylenol 3, but Tylenol 3 was very hard on me, so I took extra strength Tylenol. Does any of you gentlemen have experience with this particular trial and its side effects? And did it improve your condition and or control the cancer to, say, give you another 3, 4, 5 years? I just wanted to ask. Those were my questions.
Nazir, can you remind us what the trial is?
3475.
No, I mean, what drugs?
For the drugs, yes. Docetaxel and Keytruda.
Okay.
Okay, and the Keytruda is double blind.
Right.
Everybody is getting
Everybody gets docetaxel.
right, and the Keytruda is double blind. And I think the issue, if you don't mind my saying, Nazir, because we talked at length last night, I think the issue for Nazir are two things, and this is what he wants to hear back from the group. First is pain control, because they gave Nazir a codeine mix with Tylenol, which he couldn't tolerate. His stomach couldn't tolerate. It gave him the runs. So he's basically reverted back to Tylenol, and I suggested he speak to his docs about different pain methods. And one of the things we talked about for controlling pain is medical marijuana, which a lot of you have experience with on this call, which is available to him. And the second issue is, when are they going to unblind the trial? Because as Nazir says, if he's only getting docetaxel and from the side effects, which are not great, but they're not that serious, they're not that bad, having done already 4 rounds, then he could just get docetaxel locally. He doesn't have to travel 50 or 60 miles each time to get his docetaxel. So, and I see Dr. Mark has some suggestions, and Dr. Mark's allowed to give medical advice. We are not, but there are certain people on this call who can give medical advice, and one of them is Dr. Mark. So, Dr. Mark, what are your thoughts for Nazir to discuss with you?
Well, I'm a retired fertility physician, and if he wants to get pregnant, I can help. I think Tramadol, 100 milligram extended release, might be something that he might be able to tolerate and often does well.
Thanks, Mark.
And I guess, can I come in and make an appeal, Nazir, that clinical trials are really important for us?
Yes.
And that if you're going to get Taxol anytime, and you have the choice of being in this trial, and if you can possibly stick it out, I would hope you could.
Yeah, there are 10 sessions, and on where is this? Yes, and I'll be going next week for the 5th session, so I'll be there halfway. But my legs are giving me a lot of problems, and actually I have chemo head also, so I don't know if I can last that long.
I mean, if you're having a lot of negative side effects, then yes, you could drop out of the trial. That's not an issue. And I think the physicians in the trial would be derelict if they kept you.
Nazir, do you know what's causing the pain in your legs? Do you have any swelling?
No. If it was one leg, I can say yes, there would be a problem. But both legs are painful, especially the day after the infusion.
So are you having like a peripheral neuropathy? Could you tell?
Yes, numbness in my fingers.
Is there swelling in your legs?
No swelling in my legs, no.
Okay.
Nazir, this is Jake. I'm also on docetaxel, and I have definitely had, in the last 3 or 4 months, developed leg pain in both legs. to the point where I actually use a walker. You know, she calls it peripheral neuropathy. I'm not sure if that's what it is. And mine is pretty much constant. It's not just after the day of, it's not just the day after the infusion.
Yeah, it starts the day after the infusion, and it lasts for about 5 or 6 days after that. But it takes longer to recover, and then you go back to getting the docetaxel and starts all over again. So I just wanted to find out, and thank you very much for telling me.
Well,
You are also having some problems with the legs. So
How do you do at night sleeping? Do your legs bother you at night?
Yes, it does bother me more so at night.
Yeah, when I went through this, I had to switch ends of the bed so my feet were against the wall. I found some relief if my feet had something solid to press against during the night. Otherwise, I couldn't sleep.
Oh, well, thank you very much for telling me this. I shall try that.
Yeah, try it out. I don't know if it'll help.
That's different than what I've been having. Mine is when I walk. My legs don't bother me when I'm sleeping, but they bother me when I walk on them. So it sounds like I have something a little bit different than you do.
Yes,
I take vitamin B6 for it, and that seems to help a little bit.
Yes. It does bother me walking also, because I'm not actually walking, I'm wobbling. This is what happens.
Yeah.
Two things. The first is I'd like to ask Herb, typically, when would they unblind this trial? Would they unblind it when he leaves, or would they wait and unblind it only after they get the results?
I mean, I don't know that they would unblind it if he left, that tell him at all if he left the trial. If you leave the trial, we thank you very much, and you're out of the trial. So they will not actually unblind. They will just say lost to follow-up.
Okay.
So
They may
won't
not even
tell him.
unblind a trial ever even for people that
They
finish.
will unblind. I mean, clearly they won't associate one patient with one result, but the Data Safety and Monitoring Board will be looking at the overall results, right, of the trial. And basically, so many patients in the two arms. What are the and I didn't look at the criteria, but I'm assuming they're the standard criteria of radiographic progression and PSA. So that they will look at periodically, because if there's a huge difference, they'll want to stop the trial, or at the end of the enrollment, they'll just wait. But they will usually not tell patients what they got until the trial's ended.
Okay. Next question is, what experience does anybody have, especially on chemotherapy, using medical marijuana to alleviate pain?
This is Doug.
Yes, go ahead.
Well, I use multiple things, so I don't know if it's. I'm sorry, I'm getting feedback. I'm going to try this on my speaker.
Yeah, no, it's not you. It's coming from Lou. We'll silence. We'll just mute Lou for the second. He's muted. Try again.
Okay, so I'm doing multiple things for pain, not the least of which is oxycodone, and that's probably my main control of pain. But I use medical marijuana every night, and I use that in combination. It helps me sleep. It levels off all the, what I find is at the end of the day or towards the end of the day, I'm feeling bad just in general, or if I'm just feeling bad in general, the marijuana will tail off, will just kind of damp out everything as you would, like the damper of a piano, and it just kind of levels things out without messing your mind up too much, because it does have the getting high effect with medical marijuana. but I do use it. I was using it before I ever had cancer though, so I've been a long time cannabis user. So I continue to use that today with good results. The only thing is there's different ways of taking it. One of them is vaping, where you vape it into your lungs, and the other is edibles. But the edibles, you can't really control how much you're taking, and it takes about an hour to 2 hours for it to take effect. So you may find yourself higher than a kite than you ever wanted to be, because you aren't really controlling the intake of the dosage.
When you say higher than a kite, do you use a combination of CBD and THC, or is the THC very, very small?
No, it's combo.
It's a combo. Okay, so for those of you who don't know the difference, the THC is more of the I've got these docs and scientists on the phone, but it's more of the sort of the hallucinogenic what's the word I want?
Psychoactive.
Psychoactive, thank you. It's the psychoactive portion, whereas the CBD helps you with some of the physical symptoms.
Yeah. Now I have found that if you can get them, is that the suppository versions of this help with the prostate without giving you any kind of a high. And so I've been using those on occasion when it's just I'm just uncomfortable all the time. I'll use a suppository, but unfortunately they have been kind of few and far between recently. So, but that is something to consider if you're in a state that's got medical or it's legal.
And
I don't think the hallucinogenic. I don't consider it hallucinogenic at all. It's more like a relaxation thing. It can, if you take too much of it, you can get a little bit high, which makes you kind of feel anxious. But that calms down and it smooths out. So at least my experience based with it.
Okay.
Doug, as long as we've got you talking, I think you wanted to talk anyway tonight. You want to launch right into that?
I can. There were so many things you guys talked about today. So just to remind everybody where I came from, I was diagnosed in March of 18, and then went through radiation therapy, followed by brachytherapy, followed by METs in my penis. And then METs I also have metastatic in the spine and hips, and in the tailbone and other places. So I've got it just done everywhere. So and just as a quick look at what I did, we went through docetaxel first. I had to use Lunesta because of white cell blood counts was too low. I also used Claritin as a recommendation to help with the bone pain. And basically, you take it a day before, then you take it a day after, and you take it the day of, and then 5 days after that. And that somehow eliminated the bone pain that I was having. And that came from the nursing staff as opposed to from the doctors. So just a little trick that I learned there. It quit working after 5 rounds, and they moved me to Zytiga. Zytiga didn't work at all for two months, and Zytiga is abiraterone, and that didn't work for me. So then they moved me to cabazitaxel, and I've been on cabazitaxel through December. But during the middle of that, they found a growth on my thoracic and lower lumbar that they were concerned would encroach my spinal column. So I had radiation. A 5-dose radiation period. I don't know if it was this specific one that you were talking about. I doubt that, but they shot that through the stomach. And then after that, I turned to shit and basically getting sick to my stomach and started getting sicker and sicker. And I ended up with MRSA on top of this cabazitaxel. So I was taking cabazitaxel and MRSA. And recently, I finished up 6 rounds of cabazitaxel. My PSA right now is 25. my doctor who I had at Mayo Clinic, Dr. Singh, who I wasn't real happy with, you guys might remember, has basically told me to go find another option somewhere else. And he had an experimental for me set up as PT112, but they determined that I wasn't a good candidate for that from having a previous round of pancreatitis. So I'm basically in the middle of treatments and in the middle of doctors. And I have come across this PSMA therapy through my original oncologist, radiation oncologist. And he is trying to open a capability to do that in Mexico. He was unaware of it being available in Mexico at this point in time, but I also found it available in Germany. And I got some contacts there for PSMA type therapy. And that's with a deuterodium or leucodium, something 112 or something. It's some kind of radioactive ionized they put on there. But right now, I don't have a path. And I'm trying to find a path. And you guys, I know I sent you an email about it, had mentioned some of the ones that we've talked about today. But, even the enzalutamide and Xtandi and all that were not even talked about. Dr. Singh basically just said, okay, you're not going to make any money for Mayo, so I need you to go somewhere else. And at least that's the impression that I got. Right now I'm in the middle of looking for a new doctor. And I'm meeting with one, Dr. Halapolto, McHugh Halapolto with Palo Verde Cancer Centers in Scottsdale tomorrow, but I don't have a true path yet, so I'm looking for one.
Well, I mean, the first thing I would say, Doug, is if you're going to switch doctors, you've got to stay with a genitourinary medical oncologist. You have to. And it may well be that there is not another practice with GU MedOncs in Phoenix. Ken would know better than me, but I don't think so. Unfortunately, it sounds like the relationship has broken down with Singh. There are at least two other docs that I know that are qualified in his practice, but I don't know if you could move within the practice. If you could, I would suggest going to Alan Bryce.
Alan Bryce, okay.
Yeah, he's the practice head, and he's the chief oncologist at Mayo in Phoenix, and he's also a GU MedOnc, and he is very well recognized nationally, and he's a good guy. And that would be my first choice if you've got to switch, but I don't know where the relationship is between you and Singh. You might want to get hold of a patient representative at Mayo and discuss with them. But I don't think there's any way you can go to any doc who is not a genitourinary specialist at this time. I mean, that's an essential. The other thing is to switch your care to somewhere like MD Anderson, which is what Ken does, and then he has a local doc in Phoenix that he works with, a local oncologist in Phoenix. The problem is getting that local oncologist to work well with MD Anderson, which isn't that easy, either for Ken or a lot of people have those difficulties. But somebody like Korn is a really good option.
I've contacted Dr. Korn again because he left that open for me. He hasn't responded back to me yet, but I hope to hear from him soon.
Right. And another suggestion for you, somebody who keeps coming onto our radar and is convenient for you, and she is very compassionate and very smart, is Rana McKay. R-A-N-A, Rana, last name McKay, M-C-K-A-Y, and she's at UC San Diego, UCSD, which is a doable drive for you. And you wouldn't have to see her every time, but I think, and we probably can help you get an appointment with her, but she's very, very nice, and she's very smart, and she's tuned in.
Okay. No, that's great. That's great information.
Yeah, and I think I've got Rana McKay's I'm pretty sure I can put her profile in the chat window for you.
Okay.
So those are some initial thoughts.
Those are some great thoughts. I really appreciate that, because getting my focus is the hardest part. Where do I go? What do I do? And that's where I was last time when I stayed with Singh. It was like there was so much. You guys are so knowledgeable, and there's so much going on that it's hard for a guy to come in and say, okay, this is what I should do. This is who I should go see. What decisions do I make? You know, it's in town versus out of town, all those kinds of things, and it makes it tough on the new guy coming into the group, and so that's kind of why I stayed away for a while, because I would end up getting very confused. And but this is a good direction, and I do want to talk to Dr. Bryce, because I wanted to find out who was the head of that group, so that I could talk to him specifically about what I'm getting fed, because I think what I'm getting fed is get out of my office. But I'm sure Dr. Singh would not say that, but it's just coming across that way.
Well, I can definitely put Bryce's profile in, because I know I've got that for sure, and I can find both of them, so we'll put both those profiles in for you. But you know, I think the question for the group is what thoughts they might have, because you have this very unusual cancer that is you know is proving difficult to treat. That there are lutetium trials in this country going on. Maybe some guys can offer some information on the lutetium 177 trials that are going on in this country.
Yeah, that's what it was called, lutetium.
Herb, did you compile a list of lutetium trials, or is it BITE trials? BITE, okay.
BITE, not lutetium. I'm doing a lutetium search even as we speak.
Oh, okay.
Yeah. Peter, you were working on the. Was it only Peter? Was it only gallium, or was it only screening, or was it the lutetium trials too?
It's only screening, but I did notice that there was a lutetium trial, I believe, out of Houston.
Okay. Okay.
Doug, for Nazir's sake, I think he might be interested. You were telling us about your use of medical marijuana along with the opioids. Did you find that it reduced the need for higher doses of the opioids, or not?
I'm on the. Were you asking me or asking?
Yeah, I'm asking you, Doug Matthews.
Yeah, so I haven't had to increase the amount of opioids I'm taking. I take a extended release in the morning and in the evenings. Each one is 10 milligrams. And then if I have breakthrough pain, then they give me the immediate release, which I do have in the penis sometimes, is the main area that I get that in. Although sometimes it's the bones, and thinking about the bones, I've had both the peripheral neuropathy feeling in my right femur, as well as my left femur has had some pretty good pains associated with it. But two different mechanisms. I'm pretty sure about that. But the medical marijuana keeps me from having to, I will avoid using the immediate release, and I'll use the medical marijuana to minimize how much oxy I'm getting, because one effect of oxy, as you probably all know, is constipation. And I just recently was put on a new drug after going through some terrible constipation bouts. But they put me on a new drug that's called Movantik. I don't know if any of you have heard of that, but it attaches to the opioid in the place that causes the constipation, but not the places that it relieves the pain. So it gives you still get the pain relief, but you don't have the constipation with it. And I've been on that for a week now, and that's done a good job.
Oh, good. And that reminds me, Nazir, I think it was you or Rick speaking on your behalf said that you stopped taking the codeine with Tylenol because of diarrhea. I would guess it was probably the docetaxel, not the codeine that was causing diarrhea, because as Doug just mentioned, all opioids, if anything, they'll cause constipation, not diarrhea.
Now, I had never had diarrhea. The only problem that I had with the Tylenol number 3 was the reflux that I was having at 4 or 5 in the morning, and that bothered me. So I stopped it, and I just take the ordinary extra strength Tylenol, and for a few days now, I don't have that reflux.
Okay, good.
So for reflux, I take Nexium as a religion, one every morning, and I've been doing that for quite some time now because I developed reflux with this disease too.
Oh, so what are you taking for the reflux, please?
Nexium.
Oh, Nexium. Okay, fine, thank you.
All right.
Now, I just have one more question. Is there anyone on this trial or not?
Anyone on a trial with docetaxel and pembrolizumab?
Yes.
I don't think so.
Okay. Or Keytruda alone?
Not right now. We don't have anybody. We've had several people that have been on Keytruda, and but we don't have anybody right now that are on Keytruda, although Len is quite knowledgeable about the side effects from the Keytruda. Are you not, Len?
Well, yeah, I mean, generally there's the cytokine release syndrome where you have low blood pressure. You could get nausea and vomiting. They tend to give you prophylactic anti-inflammatories like prednisone or something like that, dexamethasone, to keep the inflammation in check, and they keep you well hydrated. So you're well, Mark Perloe is probably more knowledgeable than I am about how to treat such cytokine storm problems. But yeah, I mean, there's you could develop autoimmune reactions, Nazir.
Yes.
It could attack cells in your colon. You could develop colitis. I think that happens fairly frequently with ipilimumab.
Yes.
Sorry?
Yes, sorry. I did not have any of the diarrhea accompanied by docetaxel or the Keytruda. So
yeah. Well, I think I agree with Rick that you probably didn't get the Keytruda. It doesn't sound like you've had any side effects that you would expect to see from the Keytruda.
oh, that's good. That, I don't know whether that is good for me or bad for me. I never know that.
Well, the one thing you did not share with the group that I think they'd all like to hear is that it's driven your PSA down from 80 to 15 so far.
Yes, it did.
Right. And the other thing that the group should know, and just bear with me 1 second, is God bless him, Nazir is 84. And to be going through this at the age of 84, he was diagnosed at age 73 and in 2009. And I just want you guys should know, this is prostate cancer. You can manage it for a very, very long time. And, Nazir, I always tell him, is 84 going on 65. We've had the good fortune to meet when I visited Professor Bill, God rest his soul. And And the best thing about Nazir is not Nazir, it's his wife and his wife's cooking, which we've sampled, which is better than any Indian restaurant you'll find anywhere. And but Nazir, I'm sorry, you wanted to say something.
No, I just laughed, that's all.
That's probably the best medicine of all.
Yes, you're right. That.
That and chicken soup.
And Nazir has a son who is a medical resident, so that's also helpful.
So I just have one quick question on this trial with Keytruda. Do they have criteria about your MSI, whether it has to be high or do they check it, or do they not even care?
Well, we went through this with them, and I also went and got the proper blood test done, whether to see. I don't have an MSI. It's what did they say? It's
stable.
No, it's undetectable or something, or they couldn't tell me whether what the position of my MSI was. However,
undeterminable.
Yes, undetermined. That's the one. So these people, when they started me on the trial, they wanted a sample of the tissues. Well, they couldn't get a tissue sample of me because my lymph nodes were not that big. And they said that we'll go back to the 2009 biopsy and get a sample from the hospital of that particular biopsy. And they did that, and they started me on this trial. Now, I also have doubts whether I'm getting the Keytruda, because I don't think so. So I don't know, there was the situation of MSI, whether they resolved it or not. They just offered me the trial, and I accepted the trial.
Okay. Yeah, it's pretty uncommon, Nazir, that you have MSI high. I think it's something like 3% of prostate cancer patients are MSI high. So that's not surprising.
Well, what are you saying? In other words, you're saying that if they couldn't determine the MSI, then I should not have been on this trial?
Well, no, I don't know what the conditions of the trial were. That was basically Peter's question. He was wondering, in order to get the Keytruda, did you have to have an MSI high status? I think the answer is no, because according to Rick, what Rick told us about this trial, it was double blind for the Keytruda. So neither the doctor nor the patient knows if they're getting Keytruda. So they didn't pre-select patients for the Keytruda.
Yeah.
I think the point to take home for everybody on the call here is that, one, if you get a genomic test from Foundation Medicine, and I think now some of the other people that test too, it will give you an MSI. It will try to give you an MSI measurement. Sometimes it comes back undeterminable, as it did for Jake the first time, and it did for Nazir. Secondly, the other take-home point is that Keytruda has been approved in the United States by the FDA if you are MSI high, no matter what your cancer. So there is a bucket approval, what they call a bucket approval, a pan-cancer approval, that if you're MSI high, you're likely to respond to Keytruda.
Thank you.
Okay, if we can move on, we can go to Dennis Correa. I think you said you had a quick update for us.
Yes, I do, Len. I also got my COVID shot, number 1.
Congrats.
Yesterday. And other than a little soreness in my arm, I'm doing good. That. and I got 6 months into my drug holiday, got my blood results, and my PSA has gone up very, very slightly from a less than 0.1, where it's been since March of 2018 is when I reached that nadir. And it's gone up to now they're reporting it as 0.1. So it was something less than that 0.1 before, now it's 0.1. So still very low, not rising very quickly. And my testosterone, which was also at less than 1 for quite some time, is now at 9. Not a big deal either, but no real benefit at that level to having the testosterone go up. So it's 6 months time, it's if something's starting to move again, but not necessarily requiring any treatment at this time. And we'll just go to another 3 months and see what's going on at that point. So any inputs from Len or Peter, who's been on intermittent for some time?
Peter, you want to start?
Well, I'm no longer on intermittent, so I can't really comment, but that's great to hear that your PSA is pretty stable. Just keep going, just look over your shoulder every once in a while, but enjoy life.
Yeah.
Dennis, I would say, yeah, enjoy your drug holiday for as long as you can, probably at least until your PSA is detectable by one of the more sensitive scans, like the PSMA PET scan, so that they can see where the lesions are. Maybe you'll be lucky enough to have, assuming it goes up to something like 1.0, they can find a single spot or 2 spots that they can hit with radiation, do a little spot radiation, buy you some more time.
Yeah. The other question I had, I guess Rick stepped away. I've got a bad left hip and it's arthritis.
Yeah.
And I've also had in my left femur, one of my mets. So I'm looking at hopefully getting a hip replacement done here once COVID stuff dies down and I'm a little more confident going into the hospital for surgery. And I should have my second COVID shot by that time also, so that'll help. But a little concerned. I know Rick has had a hip replacement done, and he's given me a good recommendation for a doctor. But I need to do a little more follow-up and whether or not this doctor has done this surgery on someone with a prostate cancer metastasis in that general area, and how that impacts or could impact the surgery. I do have another recommendation for a doctor in the Phoenix area, a surgeon that Dr. Singh and my local doctor has referred me to for possible work on a hip replacement, because that person has done the surgery on people with the prostate cancer met in that location. So Rick, I don't know if you had found out whether or not your surgeon there, Perloe, I think it was, had experience doing it on somebody with cancer in the bone there.
No, because thank goodness that wasn't my situation. But there are a couple of things to bear in mind, I think, with the hip surgery. One of which is that if you can get it through, if you can get it anterior from the front, it's much less invasive and the recovery is a lot quicker.
Did you do the robotic assisted surgery for that?
He started doing that about
3 or 4 months after I had, because I recommended somebody to him, and she had the robotic assisted. He wasn't doing it. He hadn't started doing it when I saw him. But it doesn't seem to have made a difference. And the robotic assistance is basically only to make sure that the hips are level and the legs are level. That's where the robot comes in.
Yeah.
But I would definitely make an appointment with him and ask him. Petrolac, I think is no, not Petrolac. What was his? I think Ed.
I got it right here.
I'm trying to. You can remember my doctors better than I can. I'll find it for you. But he was a good guy, and I don't have any. I would have absolutely no hesitation in recommending him. And
yeah, Petro is his name. Petrow. Yeah.
Yeah, Petrow. Yeah, Petro. And he's great. So ask him. And but I can tell you, he does do anterior. You know, it may well be that depending where the Mets are in the hip, they have to adjust whether they may have to do anterior or they may not be able to do anterior. That might influence their decision. But I don't know. But yeah, it would be a concern to me.
Okay. The other question, comment regarding neuroendocrine cancer, where the prostate cancer has been known in a significant number of individuals to morph to the neuroendocrine. And then there's also evidence of long-term ADT promoting that activity. So the doc I've seen for my blood work here has suggested chromogranin A. And my research has shown that yes, maybe, no, you know, and whether or not that is a good indicator or biomarker. Serotonin, serum serotonin is another one. And when I go back, I'm going to give them a urine on a 5-H1AA.
That's serotonin.
Serotonin, 5-hydroxyindolacetic acid.
There's two separate. One's a serotonin blood, and the other is a urine.
Right.
Yeah.
Yeah, it's just like a metabolic product.
Yeah.
Same thing, basically.
Yeah.
So did they do a chromogranin A level for you?
Yeah. Yeah. The first one came back high, outside the range. At 157, the top of the range is 140 grams per deciliter.
Yeah, that's keep an eye on that.
Yeah, I don't know if that's, you know, the other thing, after I looked it up, it says it should be done fasting. And when I, you know, went to the lab, nobody told me that I was supposed to be fasting. I'd never do for when I have my regular test. So I don't know if because I was not fasting, I had breakfast, you know, and then went to the lab, and if that would cause it to be high.
Yeah, I'm not familiar with that, but I guess it's possible.
Yeah.
Len, I have a question for you. Why do these markers, chromogranin and serotonin, why would they be an indicator that the disease could have morphed into more like small cell neuroendocrine disease?
Well, it's just, you know, from empirical evidence, they've seen that these neuroendocrine cells produce chromogranin A. You know, it's just a biomarker, Rick, just like PSA is a biomarker, PSMA.
Well, it's more than a biomarker. Chromogranin is a secretory granule. So the neuroendocrine cells use chromogranin to actually secrete things that they're supposed to secrete. So it's a functional indicator of a secretory cell. And the fact that serotonin is high is an indicator that they're making hormones that are related to endocrine system?
Well, the serotonin result was actually within range. That came back at 72. That's the serum serotonin. 72, and the range is 56 to 244. So
Right. So it's sort of mixed, is what I'm seeing, Dennis. It's sort of a mixed.
yeah, that's kind of
Some
conclusion
markers.
a neophyte like myself has come to from just researching this thing. I'm not getting overly excited about it at this point in time. And next time I get checked, I will follow the procedures for prior to having the blood draw fasting.
Yeah, there are other biomarkers for neuroendocrine cancer, which I don't have memorized, but I could send it to you in an email.
Can you hear me?
I appreciate that, Len.
Okay, let's see. Carl, would you like to go next? Carl Foreman?
Okay. So right before this session began, I was on a telemed call out to San Francisco at UCSF with Dr. Pamela Munster, who was originally introduced to me by Rick as one of the top researchers in the country relating to people who are BRCA2 positive. So I had a follow-up appointment with her earlier to discuss my current dilemma, which is in regards to what my next treatment options may be now that my current treatment appears to be failing me. And there are several clinical trials that I have been looking at. Len has helped me, Ken has helped me, Ken Anderson. And I still continue to try and finalize my decision, although the decision may be made, lose my voice, may be made for me, because earlier today I also got a phone call from Columbia Presbyterian that I've been accepted into their clinical trial relating to Regeneron 5678 with cemiplimab, which is a immunotherapy. It's a small trial. It's extremely hard to get a spot in that trial, and they want me to go to to Columbia Presbyterian next week. It's probably going to be next Thursday for me to go for preliminary testing and reviews and blood work, and I would expect to be there for several hours. And then the treatment would probably start the week after, and the treatment would be infusions of the medication every week for the foreseeable future. And for the first 4 weeks, I would have to be monitored directly from the hospital. So I would be either overnight or 2 nights in the hospital for them to monitor my reaction to the medication. So that's somewhat nerve-wracking that I have to be in a hospital because they don't know how I'm going to react. But I guess on the other side, it's somewhat comforting. I don't know. So despite the fact, and I told them I want to proceed, but I do have other balls in the air with other trials. And I know there's Dr. Sam Demmead, if I'm pronouncing it correctly. I think, Rick, you know him at Johns Hopkins. And I understand he's very well versed in BAT, bipolar androgen therapy, which could be a possible treatment for me not having to go into a clinical trial. So I do have an appointment, a telemed appointment with one of his associates next week to talk about that. So I don't want to go on too much here, but bottom line is that I am looking at several scenarios and hope it'll be the right choice, but nobody really knows.
What did Dr. Munster say to you?
Yes, Dr. Munster was very helpful. She is extremely knowledgeable, very well versed in many clinical trials. Although, as she has admitted to me tonight and in the past, she's not an expert with prostate cancer, but she has sufficient knowledge and expertise. And what's also kind of interesting, there's an app called MyChart, and MyChart is used by multiple major hospital facilities, and they share information. So this morning I was on the phone with somebody with Johns Hopkins, but anyway, so Dr. Munster, bottom line, is saying to me that the Columbia Presbyterian trial looks like a really promising trial. I should pursue that at this point. If the medication doesn't work for me, they'll know sooner than later, and then I get off the trial and I move on to some other treatment.
So the RGN 5678, we first heard about some time ago, and we all thought that it was a really ingenious and remarkable trial. Len, two questions. One is, Carl, what did they say you were going to combine it with? And Len, can you remember what was so great about the RGN 5678? I know that's where your daughter-in-law works, right?
Yeah, CD28 is the antigen that they use on the T cell for one of the bispecific monoclonal antibody arms. The other arm is the PSMA on the tumor cell. I mean, on the prostate cancer cell. And so the CD28 is like a super agonist. It activates. It's necessary for the activation of CD3, which is what they're using in the Amgen 160 trial. And so it's like a potentiator. It should be supercharged, the whole BITE approach. I mentioned this to Carl. The history of the CD28 is back in 2006, they used it as a monotherapy, but it caused such severe cytokine storms that they stopped developing it. So I guess somewhere between now and then, they've learned how to come up with the appropriate dose so that it's not too toxic or too overly active. Herb, did you want to add something?
Well, I mean, I think they're using it in combination with an anti-PD-1, with a checkpoint inhibitor.
Right.
Well,
So,
yeah, that's the cemiplimab.
I mean, to me, that's a very appealing thing, because one of the things that I've read about in these trials, these immune therapy trials, is there's often exhaustion. That basically, if you don't use a checkpoint inhibitor or some other way, that basically the T cells just get used up. So logically, to me, this makes a lot of sense.
Yeah.
And what is the checkpoint inhibitor that they're using with
It's
cemiplimab.
Right.
It's an
anti-PD-1.
Right. Yeah. What's it called, Len?
I'll put it in the chat.
Thank
you. Yeah, I can do it too.
Yeah, Dr. Munster also said it's very similar to Keytruda.
Yes, it is.
Mm-hmm. Here, I'll put it in the chat.
Yeah, I already put it in there. Although, for some reason my chat doesn't send. So you better do it, Herb.
I think I did it. So.
Yeah, you did. Thank you.
Okay.
So it is very similar to Keytruda.
Okay. Okay. I mean, that sounds like an exciting trial. I mean, I do remember when we first heard about this RGN 5678 was a trial that I think Charles Drake was the principal investigator.
That's correct, yes.
Or is. And he offered it to Jerry Deans about a year ago, but at that time it was still, it may still be, but at that time it was just beginning phase 1, and Drake wasn't that comfortable putting Jerry into it. Plus, Jerry wasn't local to Columbia Presbyterian as you are. He's down in Virginia, in Richmond, Virginia. So they decided not to do it. But I know Len and I discussed it at length. This was a PHG, pre-Herb Geller, and so Len and I discussed it at some length, and we were really impressed with it. So, boy, if they said you're eligible, man, I'd grab it.
Right, and that's what Dr. Munster said.
Okay, and I don't even have a medical degree.
All right. Well, good luck with the trial then, Carl.
Yeah,
Thanks.
for sure.
All right. Let's get on to Jim Ward. Did you say you wanted time tonight?
No, Len, I'm good. Thank you.
Oh, okay. Let's see. I know there was someone else I'm missing.
Yeah,
Who am I missing? Who wanted time?
I asked for 10 seconds.
Oh, yeah, John. Sorry. Go ahead, John.
I emailed Alicia Morgans about my high testosterone level, and she said it doesn't matter that just the PSA does, but she did offer me a prescription for orgovyx, and I actually got it improved with my insurance. So I'm going to start that in about a month.
Oh, wow.
That's great.
Yeah.
And the insurance is covering it.
Well, I'm on Medicaid, so that's why I was really surprised they're covering it, but somehow it worked. So
if Medicare covers something, does that mean Medicare also covers it?
no, they're totally separate. Medicaid's more of a state-based thing.
Okay.
Well,
that's great.
Oh, Paul Frieda needed time, but I think he's left.
No, I'm right here.
Oh, you're still there. Good.
Go ahead, Paul.
Okay, just a couple of quick things. I'm happy to report my PSA is still less than 0.1, and I'm now in 2 years on my Lupron holiday. So that's very encouraging. And the other thing is that I had a really bad experience of a kidney stone. The lower left, it hurt, and then it just wouldn't go away. And so I drove to the ER, and I almost passed out driving myself to the ER. And but took them like almost 2 hours to give me the morphine when I got there. And I had endured for an hour at home before I went to decided to go. So I was really kind of annoyed that I had to suffer for that long a period of time. Then they sent me home with some medication, and about 3-4 hours later, the stone passed. But it wasn't a very nice experience. So anyway, I got my primary care physician to give me some Percocet, so because I'm sure I'm going to get another stone, and this way I'll have some medication on hand to make the situation a little more livable.
So I got that T-shirt, and it is incredible pain. And I will say that you are a very fortunate man to have passed it within 4 hours, because not many people have that luck.
Well, the CT scan said it was small, and so I guess I got lucky this time. But 6 months before, I had a stone come out that was absolutely huge. I mean, my primary care physician said it was very large, and the analysis showed it was calcium carbonate.
Right.
So,
which is.
So anyway, I get the pain like several times a week, but then it goes away. But I know, sooner or later I'm going to get the pain, and it's not going to go away. So so I got to change my diet and drink lots of fluids.
You got it. You got it. My story, and some of you guys have heard this before. My story with the kidney stones was that because of the kidney stones, they found a kidney cyst. And because of the kidney cyst, which turned out eventually to be benign, they followed it for about 3 years. They found my prostate cancer, and my prostate cancer wasn't quite so benign. So I was very, very, very lucky.
Yeah.
Okay.
That's all I've got.
And so, Paul, as I recall, you were originally diagnosed Gleason 9, right?
I was what?
Weren't you diagnosed Gleason 9?
No, I'm a 4-4. The last time I I started out 3-4, and then when I went to Memorial Sloan Kettering for the prostatectomy, I brought my samples with me, and they upgraded me to 4-3. And then after the surgery, they said I was 4-4.
Okay. Well, anyway, congrats on the 2 years of drug holiday.
Yeah, I'm really happy about that. Yeah.
Good.
Len, I've got to issue an apology here. I see guys coming in at 8 o'clock Eastern, and I made an error on the original on the reminder this week. As most of you know, the Tuesday meetings always start at 6 o'clock Eastern, and the Monday meetings start at 8 o'clock Eastern. So it was my error. And if any of you are regulars and coming in this late, we call it doing a Jimmy G. So Rusty, as you well know, our Tuesday meetings are 6 o'clock meetings, and I apologize to you and anybody else that just came in, Alan Moskowitz, if you thought that this was a 8 o'clock meeting. Sorry. Now, some of you may have thought it was an 8 o'clock meeting and you didn't notice my error. Who's going to fess up to that?
Nobody.
No one.
All right. Well, I have an 8 o'clock hard stop. If we're going to continue this, someone else is going to have to take over the moderator role. So.
Yeah, I mean, we've got a hard stop in this room in about 10-15 minutes because the multiple sclerosis folks are using it. But that said, I'm happy to keep going if anybody would like to. Look who's here, and Joe's with us too. Oh my goodness. So yeah, if anybody's got anything they'd like to talk about, Len, I can handle this for another 10 minutes.
All righty, guys, and I'll say good night. See you next week.
Take care, Len.
Thanks, Len.
Bye-bye. Thank you.
Thank you.
I think we've got a couple of people that we haven't identified on the telephone. Anybody on the phone who would like to stay on the call? We've got 2 callers on the phone.
Harry Spila.
Oh my gosh, a voice from the past. Harry, how are you?
Good, good.
Oh, yes. Glad to hear you. And who else is on the phone?
It's David Moslin, Rick.
Oh, hi, David. Okay, okay. So who is here tonight that would still like to speak or raise something and has not yet had a chance to talk? We also have somebody who identifies as Marjan. I'm not sure who that is.
Hi, this is me. Oops, my camera.
Who is this?
Hi, this is me. I don't know why you're all men. You don't have any female in this group?
Well, what group were you looking for?
Okay, well, I have a little bit unique case here, and
Just answer my question, dear. What group is it that you're looking for? What support group are you looking for?
Well, it doesn't matter. I'm looking for MS patients, okay?
Okay, that meeting starts in half an hour. So you're
Oh,
very welcome, and there will be men and women, and that meeting will start at 8:30 Eastern. Okay? This is a
okay.
prostate cancer meeting.
Okay, sorry
Okay?
about that.
So please join us exactly the same way in half an
Okay.
hour.
Okay, so it was early. Thank you. Sorry about that.
No problem. No problem. Goodbye. One of the things I have learned over the past several months is always ask people that I don't recognize which meeting it is they want to join. And most of the time, if I don't know them, I find that they are in the wrong meeting. So sometimes it's easy to tell. Anyway, that said, anybody, Harry, God, we haven't spoken to you for so long. How are you, and what's going on with your disease?
Yeah, I was just checking in. I tend to watch them on YouTube. Tuesdays are tough, but I just was going to call in and give an update. I missed the beginning. I didn't know if this meeting going to be shorter or something. I didn't hear the beginning.
No, the meeting started at 6, and our Tuesday meetings always start at 6, and I blew it and put the wrong times, which happens once in a while. It hasn't happened for a long time, but I put the wrong times on the
Okay. Yeah, that's why it's usually tough for me to call, and that's why I called in today, because they had a later time. But
yeah, on Monday meetings are always at 8 o'clock. So first and third Mondays are always at 8 o'clock, which would be 7 o'clock Central.
7. Yeah.
So tell us what's going on, Harry.
Well, just an update. I've been off Lupron or ADT for about 25 months now, and my PSA is just slowly starting to inch up. It's currently at 0.7, but my oncologist wanted me to get a Examen scan, which I just did, and there's a couple highlights on a couple spinal highlights. So we're talking about getting an MRI to maybe better identify location and size, and then we're talking about next steps and maybe going back on the ADT and then possibly some radiation. So that's my update right now. So.
Well, it's a shame that Len's left, because I think he's great to talk about intermittent and when to go back on, and Peter did intermittent and then went back on, and there may be other people that have had gone back on as a result of spinal mets. But yes, I mean, probably means you. I think if it were me, I would probably want to go back on, and I'd be looking for some SBRT to those mets. Who's got some words of comfort and advice for Harry with his disease moving along?
Well, it's good. It's good that you. It's good that the Oxymen scan picked something up at 0.7. Usually, you got to wait till on Oxymen until it's like 2 and above on your PSA before it'll really tell you much definitive. But if it picks something up, that's great. There might be something more, but at least you got something to work on about where the action is.
Right. We've been, my oncologist has always been very proactive, and as long as, we could get insurance to cover things, we've gone for it. So, I appreciate that approach. And yeah, I think I'm going to go back on ADT, even though I had a horrible experience with it. I'm not looking forward to it, but, the alternative's not good. So.
What kind of ADT were you on?
I started out on Lupron, and then because of insurance reasons, switched over to the what's it called? Calodex? Is that right? Yeah. Zoladex?
Casodex?
No, I think it was an injection. Zoladex, and then
Zoladex,
and then also Casodex oral, that too. And that was I was on that for 15 months, and then I requested to stop it and see how things went, just because I was having a lot of issues being on that quality of life stuff.
Just one thing, a heads up, which is that when you do go back on the Lupron, if it were me, I would definitely want to go either with an antagonist like Firmagon, or if I was going to go back on Zoladex or Lupron, I would want to do a buffer of Casodex for at least 15 days before you get your first shot. Just like when you started originally. And sometimes when the docs put you back on, they forget to give you the buffer.
Okay, thanks for that advice. I had forgotten about that. I did do that the first time.
Yep, and a lot of times when you've been off for a couple of years, and especially if there's some action in your spine, you need to be smart enough to take that protection. So
right.
So that's and one other thing I did want to mention, because I've been going back and forth this week with the people that make relugolix, or what's it called? Orgovyx? Orgovyx, is it, John? Orgovyx. So this is the oral LHRH drug that John just got approved for. There are a number of programs. If you want to try it, they'll give you 2 months free, or they have assistance programs. So for those of you who are interested in an antagonist, then orgovyx, thank you, orgovyx, O-R-G.
Sorry, I can never remember. I had to look it up again.
Yeah, orgovyx, and I think the website is orgovyx.com. And we're talking to them because we're trying to get some money out of them to sponsor our webinars for this year. And I asked them at the same time about how they're subsidizing patients, and it's right there on the home page. If you scroll down, you'll find out how you can get orgovyx. Thank you, John.
Is that AUG, orgovyx?
It's ORGOVYX. ORGOVYX. And for those of you who are not on the phone or are there, John's put it in the chat window, and it'll be, Harry, we'll copy it into the into the recordings too. And we talked quite a bit about intermediate today, about people coming, taking a holiday, or coming back off a holiday. Came up 2 or 3 times. Okay, Harry, don't be a stranger. Come back on and see us when we on one of our 8 o'clock meetings. Please come back and see us.
So those are on Monday, you said? The 8
yes,
o'clock?
The Monday meetings are at 7 o'clock Central, 8 o'clock Eastern.
Okay, that works better.
7 o'clock Central.
Monday. First and third Monday.
First and third Monday. Yes. I keep looking at this guy, Rusty, and who is that guy? But he doesn't have a cap on. That's the problem. Put your cap on, Rusty, so I can recognize you. Mm-hmm. Okay. Well, anybody else got anything quick?
I've got one question. It's David Muslin.
Yes, David.
Any difference between Lupron and Eligard? Is it Eligard?
Peter. And there are a few people that might want to chime in on Lupron versus Eligard. Go ahead, Peter.
I was on and off Lupron for 6.5 years. I was tolerating it real well the last several years. They made me switch to Eligard 3 months ago, and I had a reaction to it right away. I did not like it. All of a sudden, it brought back the fatigue. It brought back the muscle ache. The shot itself was painful. So I just talked to my local oncologist about whether I can get back on Lupron. So I'm working on that to see if there's a way to do it. I don't know.
Yeah, so I'm down in Florida, and so I went to see the local urologist, and they gave me Eligard, but the nurse that gave it to me, so it's the same as Lupron. And I didn't think that it was, and I should have stopped her, but she gave me the shot in the stomach, but I have not felt any difference so far. Maybe I'm lucky, I don't know.
It is essentially the same. You know, I'm not arguing that. I mean, it probably does the same thing. I just had some reaction to it. That's all. I'm different. Felt it.
Okay.
David, I had both. I had 6 months of one, 6 months of the other, and I didn't notice any difference.
Got it. Hi, Jim.
They both suck.
Yeah.
As you know.
Yeah, I sure do.
Some people.
They do keep the PSA down.
Yes.
Yeah, I mean, it's going to do exactly the same thing. It's an agonist, so it's going to work exactly the same way as the Lupron worked. But some people respond differently to different LHRH drugs, and some people who don't get a reaction from one get a reaction from another. Sometimes if one stops working, like Lupron stops working, they'll switch you on to Eligard or Zoladex, and that will depress your testosterone. So you know, everybody's different. But the one thing I will say to you guys, and who knows when Lupron's going to come back on, but you know, there is a backup right now might be to get 2 months worth of orgovyx free, and then see where you go from there. The orgovyx works like the Firmagon. You don't need a buffer with it. It immediately works to depress the testosterone, and it is a daily pill, so you can start it and stop it as you know, as you wish. So
you know, just for information, Rick, I spoke to Dr. Hussein about going on it before I got the shot, and she said, well, you know, I really don't have any patients on it yet. I'd rather have you wait, take a 3-month shot, and let's revisit it in 3 months. She was her rigid self.
Okay.
Well, my oncologist said, I think it was Zoladex or Lupron, one of the two, are available in a pill form now. But she said they haven't really tested a lot.
Yeah, that's what we're talking about. That's the orgovyx. That's exactly what we're talking about. And anyway, it's there, and I have a good connection with the patient, the guy that's in charge of patient relations there. He also happens to be is Dennis McGuire still on, or did he leave? Oh, I think I already told Dennis. He's an alumni of the same school that Dennis and I both went to at different times. So, you know, we can help you. Anyway, I got Jake reminding me I've already had one of our MS moderators join the call, so I can't even say hello to my buddy Joe. Joe, we had snow in southern Arizona today. It didn't last that long, but we did have snow in southern Arizona, and the snow on the mountains that I'm looking at.
Happy New Year. Sorry I was 2 hours late or whatever I was.
That's okay. See you next time, I hope. Okay. How's that boat, Joe? Is that did you?
No, we actually got it going. I'll send you a link to some video.
Oh yeah, Joe built himself an ice sailor, an ice boat sailor that goes along. And Jim Marshall, Jim Marshall, if you come back in, to the next meeting, we'll talk to you as a new fellow, because I don't think you've been on this call before. We can't. It's really a little late to do it today.
No problem,
all right.
sir.
All right, guys. I got to shut the room because we have to reopen it so we can record the next meeting too. And Peter Monaco, thank you very much for making a lot of work for you tonight. Goodbye.
See you guys.
Bye.
All right. Peter Monaco,
everybody.
by the way, Peter is responsible for downloading and uploading all of the recordings that you hear. So a big thank you to him. Bye.
You're very welcome, Rick.
Bye.
Bye.